we have all of this data, but we're data rich, but insight poor, which is why we've taken that step, not just to look at the EHR as a productivity and an efficiency enabler, but also an enabler to have that transformative change.
Welcome to another episode of the MEDITECH Podcast. We're the leader in healthcare technology, empowering you to be a more informed healthcare consumer and provider. Hear the latest from our friends and colleagues on topics we think you should know about. I'm Rachel Wilkes, Director at MEDITECH, and today I'll be your host.
I'm joined by Farhana Alarakhiya, Chief Data Innovation Officer at Aga Khan University. Farhana is a seasoned software executive with over 25 years of experience in the realms of big data and AI. At Aga Khan University, she is driving impactful change in low and middle income country settings by combining data and smart individuals.
Why don't we start by telling us a little bit about the Aga Khan University. So it's a little bit different than maybe what other folks are thinking about traditional or typical universities.
Thanks so much for that. So first of all, thank you for having us here. So the Aga Khan University is different. So first of all, we're truly global. We're in 6 different countries: in Kenya, Tanzania, Uganda, Pakistan, Afghanistan, and the UK. The second is, for many of you, we're not like your traditional American college in terms of having standard programs. I personally am an engineer, so we don't even have an engineering program. What we have focused on when we instantiated the university were vocational programs that are important to that region. So education, so we have a bachelor's of education, focus on teaching, bachelor's of nursing, bachelor's of medicine. And moreover, with respect to having those vocations, what we also focus on is diversity. So yes, we do focus on gender diversity, but more importantly, geographic diversity. So we make it a huge goal of ours to ensure that we have people coming in from remote and rural areas, with the objective of them returning back to those communities and bringing those skill sets, education, nursing, medicine, into those communities to drive impact. So a bit of a different model.
Now, in the context of the landscape that you're working in, again, very geographically diverse, but give us a little bit of context about what the workforce looks like and some of the most pressing healthcare challenges and conditions that you're seeing in the geographies that you serve.
Okay. So I'm going to frame all of my answers in the context of East Africa, because that's where I do a majority of my work, and specifically in Kenya. So let me provide you with some statistics, right? So when it comes to the healthcare landscape in low middle income countries like Kenya, it's very different than what you have. We just talked about making sure that we have equitable access to healthcare. So let me give you some stats. Let's take HIV. In Kenya alone, you have 4.8 million people living with HIV. East Africa accounts for 25% of the global HIV burden. Let's take another stat. You just mentioned to me you have children. The maternal mortality rate in East Africa is 556 for 100,000 live births. The global average is 211. In the US, it's 22. It's 8 in Canada. It's 3 in Denmark. 556 to 3. That is a big, big difference. And so what compounds this on top of that is the World Health Organization recommends about 4.5 healthcare workers for 1,000 people. We have 1.9 in East Africa. So not only do we have a stark difference in terms of the burden from a disease perspective, we don't even have the workforce there. And this is going to continue to exasperate because we know we have growing populations, and especially in those rural areas, people now have to travel very long distances just for basic care. So that is the environment that we're operating in.
Ooh. Yeah, certainly. Certainly a lot. And over the short time which I've had the opportunity to get to know you, I guess what I'll say is that when we talked about sharing the power of data, I think you are somebody that embodies that. And I know you've been an outspoken advocate for the power of what EHR data in particular can do. Another stat you shared with me is that by 2030, data-driven healthcare interventions could save over 1 million lives in Africa. So talk to us a little bit about how you've leveraged EHR data to understand the needs and the complexity of your patient population.
So the stat you quoted is the World Healthcare Organization statistic, and it honestly is the North Star for our team, and it's what gets me out of bed every morning. And so the reason I say that is, so I gave you some stats where I compared high-income countries to low-middle-income countries, LMICs. We know we are making a big, when I say big, it's huge, a huge bet on data and EHR data. And the reason we're doing that is we also know we can't just do a lift and shift from high-income countries to low-middle-income country settings. So what do I mean by that? We know that borrowing doesn't work, and I'll give you one example. So colorectal cancer. Colorectal cancer in Kenya is 3 times higher than it is in a high-income country. We don't know why, but it is 3 times higher. And 40% of the people diagnosed with colorectal cancer are under the age of 40. So if we used high-income protocols, which start screening at 50, we would have really crappy patient outcomes. So that's one. Number 2, we will never have the resources you have in a high-income country. We won't. So we need to innovate in our context, and we need to think differently. And so this is where we are making a bet on data. And the reason that I'm confident about this bet on data is we have the potential to leapfrog. And we've done this. So the example that I'm going to give you is M-Pesa. M-Pesa is mobile money, right? It is strongly adopted and prevalent in Kenya. It accounts for 40% of the GDP. And just in 2023, $49 billion passed through it. I was literally in the middle of nowhere. Like, we're talking rural Kenya, walking from one hut to the other to do some surveillance. We went to the canteen to buy water. The only way I could buy water was M-Pesa, because in the middle of nowhere, we have 5G service. This ability to leapfrog is what we're looking to do with healthcare, to use data. And EHR data is the cornerstone of that. So we can absolutely, we have MEDITECH Expanse. We've been running it for 2.5 years now in Nairobi, in Kenya, right? Absolutely huge advantages in terms of productivity, in terms of efficiencies, operational efficiencies. But we want to now take it a step further, and that is about extracting that data, organizing it in a manner to leverage it for research. And it is there that we will see that statistic become a reality and not just something that we want to grasp for.
And something else you talked about too is using that data and changing even some of the care protocols too. So you've had a few good examples of that, I know, with the chest impressions and all. But one thing that I think would be interesting for this audience too is when you think about the concept of innovating in your context. How could we and how should we think about taking that concept of innovating in our context and apply that?
So I'm not an expert, I would say, in terms of innovating within our concept, but I can talk to you about our journey. So prior to me joining AKU, which is an academic institution, I worked in high tech, right? And I worked for the last 15 years in what you would consider to be cloud native, digitally native organizations. And I'm not saying they have everything right, but they are certain things that they do very well. So the first is about having iterative projects, right, where you take on small pieces. So I've worked for many software companies, and I've worked for traditional companies, and then I'm going to call it the cloud native. So I used to work for Shopify prior to joining AKU. We, on average, pushed 50 new changes to our software a month. Prior to that, I would do 1 release a year. So that iterative in terms of small wins, I think is a good, and I'll walk you through one of our examples. The second I would say is, I've noticed this a lot in academia, is there's a lot of focus on the process versus the outcome. And so you lose sight of what it is that you're trying to achieve because you're so focused on that process. And so if anything, I would say is, what is the outcome you want to achieve? So for us, we had never leveraged our EHR data. And so what I did when I joined 3.5 years ago is we did have a legacy EHR system. We've pulled all of that data out of Nairobi and then our sister organizations in Mombasa and Kisumu. So just out of our legacy data, which is nowhere as comprehensive as Expanse is, we have a repository that we're already leveraging. So the studies that you talked about. So we have a repository of 3 million patients, unique patients, 14 years of data. Let's tap into that first, right? And now we're tapping into Expanse. So it's about focusing on the outcome. We'd never touched it before. And then I would say the third is around experimentation. So what high-tech companies do really well is experiment. And so experiment, right? Like work with new technologies. This repository that we've built, we have changed the architecture 6 times, right, in the last 3.5 years. Because we work with open source, we work on the cloud, we're able to adapt, especially in the domain of data. The domain of data is moving so fast. Think about where generative AI was not even 12 months ago and where it is today. There used to be like really no large language models. There's 7 really good ones. We're just testing one right now on multilinguality. So like, can we ask questions naturally in Swahili or the dialects of Swahili and get an answer back? That didn't exist 18 months ago.
Definitely not. So talk to us a little bit about, population health. Certainly, you kind of touched on some of the work that you're doing there. You're working really hard to make proactive and preventative care a reality. So you talked about the issues that you have in terms of the true shortage of healthcare workers, the prevalence of some of the disease states within the Kenya in particular. So with the data that you have, and I know something else we talked about prior to this was how you're working on democratizing that data and doing that in a way that allows you to make that proactive preventative care a reality.
It's a very good question. And so the way that I would summarize it is we kind of have 3 core buckets of work. So the first bucket is we took all the data out and we organize it in a manner to optimize it for research, right? So we took our legacy system and now we have 2.5 years of MEDITECH Expanse. And what is incredibly opportunistic that we're looking at for MEDITECH Expanse is all of that unstructured data we're getting. So the doctor's notes, we didn't have that before, the surgical notes, etc. And so we have this repository, and in this case, it's only Kenyan data. We're looking to add Tanzanian data to it as well. And so we're starting to leverage that. We're very early on in that. So first, it's building that and making sure that it can be used for research purposes. So not just using the EHR as that amazing record keeper and operational efficiency, but looking at it to bring that data-driven intervention into reality. The second bucket of work then focuses on like leveraging it for population health research. And so we currently have sort of 2 projects on the go that I can talk about. Once again, very early on. We started on this work about 18 months ago, so it's pretty fresh. But let's talk about these 2 studies. So the first one is on cardiovascular disease. So cardiovascular disease is on a rise in Kenya. It accounts for 25% of all hospital admissions, 13% of all deaths. Not a great number, right? So we were looking at all of this data and still very early on, and we're talking not very sophisticated analytics here. We're talking just descriptive, looking at the numbers, right? And what we've noticed is that our rates of return of spontaneous circulation after cardiac arrest is higher. So most UK journals, what they quote is on average in high income countries, it's about 45%. Ours is anywhere from 57 to 68%. So that construct of potentially reverse innovation, we're doing something different. I don't know what it is. I'm not a physician nor a healthcare professional, but we're doing something different. So what is it? So very early on in that study. Another one that we've launched is around gestational diabetes. So gestational diabetes is traditionally diagnosed between weeks 24 to 28. So you can imagine for us, where you've got the mother traveling very long distances, that's really late. And so right now we're looking at analyzing basically pregnancy data, maternal child health data, to see if we can identify early predictors of it in the first and the second trimester. So when that mother comes in for that first checkup, we can take at least some predictors and proactively prevent gestational diabetes. We're also looking at building a machine learning algorithm, right? You might say, well, there's machine learning algorithms out there for gestational diabetes. Absolutely. But they're not in our context. We have different genetics. It's been proven, right? We have strong evidence against that. So it's about building it within our context. And then, I know it's a very long-winded answer, but we're doing a lot of work. In addition to this population health, like looking at the data we have from the EHR, we're also looking to augment it with some of our partners with other data, climate data, economical data, political data, to see what that has in terms of an impact. Are there any correlations? Are there certain things that we need to think about depending on their geographic regions? And then the last bucket of work is this experimentation bucket. And that's where we're basically running a bunch of fun experiments with large language models, right? Looking at, can we democratize that knowledge to address that 1.9 healthcare worker gap? Because we know we're not going to, with our increasing populations, this is going to continue to be an issue for us. So can that lowly healthcare worker in Kilifi, who just had a whole bunch of cases come in of cholera, ask a question in Swahili? Hey, what have we done for cholera in the past that has worked? Are there any complications that I need to be aware of? And are there certain drugs that I potentially need to look into? Just ask the question and get an answer. So those are sort of the 3 buckets of work we're working on.
And those are all incredibly impactful and, a good notion of innovating within the context and doing things that are really important to the populations that you're serving. When you talk about the healthcare workers, how are you preparing folks and equipping them to be able to leverage the data that's available to gain insights?
Yeah.
Like, what does that process look like? What are you doing?
So, like I said, our vocations are different, right? So bachelor's of medicine, bachelor of nursing, etc. So in Kenya, we launched our bachelor's programs in 2023. Prior to that, we had master's programs. So one of the observations that I've had, and so this is a bias that I'm providing here, is the people that are really good with data have this natural curiosity, right? In fact, the best engineering manager that I had didn't even have his GED, right? Like just naturally curious. And so what we've done in Kenya last year when we had this bachelor's cohort come in is we launched a student club. I know student clubs are very common here, et cetera. So for us, they're not. It was like the first student club we launched, and it's called the Data Innovators Club. And so where you have people that are in the Bachelor's of Nursing, people that are in the Bachelor's of Medicine program, we invite them to be members of this club, completely student-run, but supported by our team. And so what we're teaching them there through fun activities is curiosity about data. Do you understand what these numbers mean? And to catch them early versus them going through and not understanding that. So I'll give you 2 examples. So the first example is a couple months ago, we ran like a fun event. It was a chess match between the Dean of Medicine and the Dean of Nursing, right? So, you get a little bit of competition going there, but whilst, and so we had bets going in terms of who was going to win. But in order to make a bet, you need to understand their history. What is their track record? So therefore, through statistics, they're understanding what their track record is from a chess perspective. Second is chess is a game about math. It's all math, right? And so through that, we got to educate them around the math of chess. And then just this morning, we ran like an interactive session where we used synthetic data around maternal child health and maternal mortality, and just analyze it. Just look at the different trends. Can we look at trends over the last 14 years? Have we gotten better, etc.? Have that curiosity naturally so that when you do graduate and you are looking at EHR data and you see an anomaly, be curious to understand what is driving that anomaly. Is there something that I should look into further, So those are sort of some of the ways that I'm going to call it, we're preparing the workforce for the future.
And really an important topic too, talking about our foray into generative AI. I kind of chuckled and he said how far things have come because that's what we've been living for the past 12 to 18 months. So really critically important. And we've seen our own efforts to upskill folks and to learn these critical capabilities. So that's great. Are there any, would you say from your perspective, any specific decisions or actions that you've taken at a leadership level in your organization to make any of these notions a reality in terms of how folks are using data or how you're enabling them to get this training and to take these next steps and progress?
I would say it's about getting them comfortable with data, right? I have a saying and it's called drip, right? If you think about the world we live in today versus the world we lived in, let's just say, I'm going to age myself, 25 years ago, right? With the advent of the internet, we are surrounded by data. We know we can't do the things the way it's done in high income countries. We know that we have to innovate within our context. And in my previous life, we've taken that data from these record-keeping systems and honestly delivered unimaginable value. And so that is what we're looking to do. So A, making that investment, right, to build a repository, then B, starting to leverage, but using technology, like the pace that data is moving at is very fast. So not being sort of strung with looking at things from a traditional sense. So using some of those lessons from these digitally native cloud organizations, the experimentation, the open source, and then making sure that we enable the workforce with that curiosity to become data savvy. Like being data savvy in today's world, I think is extremely important because when you look at numbers, right? So for example, the ability to read news headlines and interpret those numbers within context is really important. 4,500 people said this. Yeah, but is that 4,500 out of 100,000 or is it 4,500 out of 10,000, right? That makes a big difference. And so having that natural data savviness is important, not just as human beings on this earth so we can interpret, but also for us in the context of healthcare.
Any closing thoughts that you want to leave us with? I mean, we've talked about, I think, this notion of innovating in your context and understanding your populations and healthcare being personal and local. So really having this deep understanding of what we all can do to serve those populations and to train up our workforce and make sure that folks are innately curious about how they can leverage data. Those are really awesome takeaways. But anything else? Any closing thoughts you have?
If I were to say something, it would be around the potential healthcare has, right? If we look at what data has done in other industries, like we're talking incredible, remarkable change. We're seeing that. We know, regardless of whether you live in a low middle income country or a high income country, we cannot keep with the current cost of healthcare because there isn't so much money. We only have so much money. So we have to find different ways. And so me, speaking as a data person, I completely acknowledge I have a bias. I'm telling you, make the bet on data. To find those data-driven interventions. If you're just going to use your EHR to increase efficiencies, I think you are shortchanging yourself. It's not just about the operational aspect. In order for us to address globally the healthcare challenges that we're facing, we need to think differently and we need to innovate. And I'm telling you, make the bet on data.
Thanks for tuning in. Stay informed and subscribe to the MEDITECH Podcast, and we'll talk to you next time.